Good morning. I'm Dr. Victoria Canlasi Dolor, the President of the Association of Thoracic Anesthesiologists of the Philippines, or Astaphil. In behalf of Astaphil, I would like to thank the Philippine Society of Anesthesiologists for inviting us to be a part of PSA at 70, 53rd Annual Convention entitled Rewiring the Anesthesiologist's Mind, a collaboration of experts. Astaphil's topic, which is Challenges in the Management of Central Airway Obstruction, a multidisciplinary panel discussion, is indeed a collaboration of experts. It is with pleasure that I introduce our distinguished panel of experts. Dr. Mariano Sanchez is a pediatric pulmonologist, had her Doctor of Medicine at the FEU Nicanor Reyes Medical Foundation Institute of Medicine, fellowship training in pediatric pulmonology at the St. Luke's Medical Center in Quezon City, head Task Force in Pediatric Bronchoscopy of the Philippine Academy of Pediatric Pulmonologists Incorporated, an active consultant of the St. Luke's Medical Center in Quezon City, St. Luke's Medical Center in Global City, and at the Los Santos Medical Center. She is a visiting consultant at the Lung Center of the Philippines. Dr. Marie Charisma Laborte de la Trinidad is an adult pulmonologist. Had her Doctor of Medicine of the UERM Memorial Medical Center, fellowship training in pulmonary medicine at the Lung Center of the Philippines, fellowship training in critical care medicine at the Lung Center of the Philippines, a medical specialist too, and an active consultant of the Lung Center of the Philippines and Quirino Memorial Medical Center. Dr. Norman Manlapaw is a thoracic and cardiovascular surgeon. He had his Doctor of Medicine at the West Visayas State University in Iloilo City, fellowship training in thoracic and cardiovascular surgery at the Lung Center of the Philippines, an active consultant at the Riverside Medical Center in Bacolod City. Dr. Edmund Villaroman is a thoracic and cardiovascular surgeon. He had his Doctor of Medicine at the University of Santo Tomas, fellowship in thoracic and cardiovascular surgery at the Lung Center of the Philippines, Chief Thoracic Division of the Lung Center of the Philippines, Head Thoracic Division, Institute of Pulmonary Medicine at St. Luke's Medical Center, Program Director, Thoracic Surgery Center for Excellence Program of the Lung Center of the Philippines, a board examiner of the Philippine Board of Thoracic and Cardiovascular Surgery, founding member of Asian Society of Thoracic Surgery, and a faculty member of the Asia Thoracoscopic Education Platform. Dr. Maria Stephanie Balawing is a thoracic anesthesiologist. She had her Doctor of Medicine at the University of Santo Tomas, fellowship training in thoracic anesthesia at the Lung Center of the Philippines, medical specialist and an active consultant of thoracic surgery and anesthesia department, Lung Center of the Philippines, a cluster head thoracic anesthesia at the St. Luke's Medical Center in Quezon City, a training officer of the Lung Center arm of the Department of Health Consortium of Anesthesia Residency Training Program. Dr. Mac Dinsem Pabalinas is an anesthesiologist. He had his Doctor of Medicine at UP Manila, fellowship training in thoracic anesthesia at the Lung Center of the Philippines. He is a visiting consultant at Riverside Medical Center in Bacolod City. Dr. Catlea Teresa Hironella Manlapas is a radiologist. She had her Doctor of Medicine at FEU Nicanor Reyes Medical Foundation Institute of Medicine. Had her fellowship training in radiology at the St. Luke's Medical Center in Quezon City, an active consultant of the St. Luke's Medical Center, the Lung Center of the Philippines, and the Medical City in Clark. Dr. Christine Marie Ilo Ramos Our moderator is a thoracic anesthesiologist. She had her Doctor of Medicine at FEU Nicanor Reyes Medical Foundation, fellowship in thoracic anesthesia at the Lung Center of the Philippines, an active consultant at FEU Medical Center, and a visiting consultant at the Lung Center of the Philippines and MCU Hospital. I would now like to give the floor to our moderator, Dr. Christine Ilo Ramos.
Thank you, Dr. Idunor, for that introduction. To discuss the basics of central airway obstruction, may I call on one of our graduates, Dr. Mac Fabregas.
It is my privilege to open this panel discussion with an introductory lecture on central airway obstruction. In the next few slides, I will tackle the basic anatomy and physiology which are relevant to the decision-making and management of this airway problem. Central airway obstruction refers to a group of lesions along the trachea up to the main bronchi, which limits airflow into and out of the lungs. After the cricoid, the trachea is composed of incomplete U-shaped cartilages on the anterior two-thirds of the wall, providing structural stiffness. At the posterior one-third is the trachealis muscle, which functions to change the airway caliber by relaxation or contraction. In average adults, the length of the trachea is 12 to 14 centimeters, and the diameter is 19 to 22 millimeters for males and females, respectively. In children, the tracheal rings are smaller and softer, hence, are more prone to collapse compared to adults. The pathophysiology of airway obstruction can be described by going back to this formula of flow rate. Assuming laminar flow of an incompressible gas, the rate of flow through a cylinder is affected by four variables: pressure gradient, radius of the channel, cylinder length, and viscosity of gas. Of these, the radius has the most significant contribution. A 16-fold change in flow rate can be gained with just a theoretical change of baseline by a factor of 2. Therefore, the most important feature to describe central airway obstruction is the extent of the cross-section area obstructed. If it is less than 50%, it is considered as mild. Between 50 to 70% is moderate, and any obstruction greater than 70% is severe. This slide shows the possible etiologies of central airway obstruction. This list is not comprehensive. Moreover, some etiologies may even coexist. Obstruction may be congenital, like due to abnormally pliable cartilages. Iatrogenic, like in prolonged intubation, or an acute blockage from a foreign body in the airway. Airway inflammation, secondary to infection, can also lead to obstruction. For example, granuloma formation secondary to tuberculosis, or plaque deposits caused by diphtheria. At the mediastinum, the airway can be compressed by lesions arising from neighboring structures like an aneurysmal aorta. Malignant lesions may be primarily from the tracheobronchial tree or an extension of lung malignancy. Large masses from the esophagus or thyroid gland can also cause obstruction since these organs share the limited space at the neck and mediastinum. Distant malignancies known to metastasize to the airway are renal cancer and breast cancer. Early disease and slow-growing lesions, classified as mild obstruction, can be asymptomatic. However, in the event of respiratory infection, the airway lumen can be severely decreased. If prompt medical management is able to resolve the infection, the diagnosis of a coexisting obstructive lesion can be missed. Other common symptoms are as follows: stridor, wheezing only on one side, positional dyspnea relieved by lateral decubitus or even prone positioning, recurrent cough with difficulty in expectorating secretions, and sometimes hemoptysis. Relative to the cross-section area of the airway, mass lesions can be described as extraluminal, endoluminal, or mixed. Along the length of the central airway, the mass lesion can also be described as proximal, middle, or distal. Each has its own peculiar implication with management. In emergency situations, a proximal obstruction can be temporized by a more distal front of neck access like tracheostomy. However, more distal lesions might require specialized interventions if it is deemed almost impossible to provide adequate ventilation, citing distorted anatomy. These are some examples of airway obstruction not caused by a mass lesion. In tracheomalacia, the weak structural support from the cartilages causes the lumen to collapse during tidal exhalation. On the right depicts post-intubation tracheal stenosis with the focal and circumferential thickening of the trachea. So please be mindful of not overinflating your endotracheal cuffs. For the workup, a thorough history and physical examination remains important. Though plain chest x-rays are the most common initial imaging, it might miss smaller lesions or those located in the proximal trachea. If central airway obstruction is considered, a contiguous CT scan of the neck and chest can be done to determine the exact location, size, and extent of the lesion. Multiplanar and 3D reconstruction are both useful in understanding how the lesion distorts the normal anatomy, which is important in planning. Bronchoscopy offers a direct view inside the airway, with the option of doing a biopsy, as well as converting to a therapeutic intervention if appropriate. For example, laser or cryoablation, coring out, or stenting of the airway. Spirometry can document physiologic effects of the obstruction on breathing mechanics. However, in patients approaching severe obstruction, the repetitive forced vital capacity breaths or testing may precipitate respiratory failure. Some mediastinal masses become very large and also impinge on the heart chambers and great vessels. An echocardiogram can be used to confirm such abnormalities. From the anesthesiologist standpoint, we get these patients as referred for diagnostics, temporizing airway access, or definitive surgical interventions. However, it is not uncommon to change the preoperative plan during the actual procedure due to intraoperative findings or events. Essentially, each individual case would be unique. Thus, management of their cases will be nuanced by the following. A stable patient would have more time for optimization. While airway access is the initial approach, the definitive management should be based on the etiology of the obstruction. Discussion with the patient should also account for his or her prognosis. And should interventions be done, what is the trajectory of the patient's quality of life? The availability of tools and human resources go hand in hand to formulate the most appropriate plans. Options for re-establishing normal airflow can also be correlated back to our previously discussed formula. The driving pressure can be increased by a spontaneously breathing patient with the use of accessory muscles of respiration. However, if prolonged, this can lead to fatigue. If the patient would receive positive pressure ventilation without bypassing the obstruction, overzealous ventilation should be avoided, as there is a risk of volutrauma in mass lesions with a ball valve effect. If the obstructing segment is resectable, normal airflow can be re-established. The remaining length of the trachea should be accounted for a tension-free anastomosis. Helium and oxygen mixture can be used to maintain laminar flow through the obstruction. Assuming all other variables remain the same, using this lighter gas mixture effectively lowers the work of breathing. However, it is limited only to 40% oxygen and is not always available. And lastly, if we'd recall, increasing the radius of the lumen of the airway is the most effective means of re-establishing ventilation. It can be by direct ablation of the lesion, dilatation by the use of stents, or a new airway distal to the obstruction, such as a tracheostomy, an endotracheal tube, or a rigid scope with jet ventilation. This is the rigid bronchoscope and manual jet ventilator used at the lung center of the Philippines. As pictured, its metal barrel is larger and longer than an 8.0 endotracheal tube. The rigid bronchoscope can provide means as an airway dilator, deploy various instruments like these forceps, while maintaining oxygen delivery by entrainment of room air from the proximal ports into the distal ventilating slits. If all aforementioned options are not reliable or deemed impossible, then a non-conventional form of ventilation like extracorporeal membrane oxygenation can be used. This requires cannulation of large vessels to pass blood through a machine. Should complete airway collapse occur, ECMO can still provide oxygen and remove carbon dioxide. At the opposite extremes, the decision to maintain full spontaneous versus controlled ventilation coincides with the contemplated techniques of local anesthetic versus volatile or intravenous anesthesia. There are, of course, gray areas where airway plans and techniques are combined or intentionally transitioned. With this limited time for introduction, I'd like to share a few caveats relevant to anesthetic management. During the pre-op evaluation, the position which relieves the obstructive symptoms can be used in the event of intraoperative airway collapse. Airway blocks are particularly useful in providing analgesia while maintaining spontaneous ventilation. However, care should be taken if this is the sole anesthetic used, since an inadequate block can lead to airway trauma if the patient reacts vigorously during instrumentation. In choosing sedatives, those which are short-acting and ideally able to be titrated to maintain spontaneous ventilation are preferred. PIVA becomes the anesthetic of choice over volatiles if ever frequent interruption of ventilation is anticipated. The use of muscle paralysis is traditionally avoided until a reliable airway is established. However, if adequate plans, muscle paralysis completes balanced anesthesia and a hassle-free instrumentation. Of course, the availability of short-acting or those with reversal agents are much preferred. And in very difficult cases, if ECMO would be part of planning, the best use is to cannulate before induction of anesthesia. There will always be an overlap of interventions and its outcomes. As such, the overarching principle of a shared airway should be taken into consideration in managing these cases. To further drive the importance of a team approach, let me turn over the virtual floor to our panel discussion.
Thank you, Dr. Pabalinas, for that concise lecture. At this point, I would like you all to listen to a case of a pediatric patient who presented with stridor. To present the various aspects of to the multidisciplinary approach in the management of this case, may I call on our pediatric pulmonologist, Dr. Marian Sanchez, our radiologist, Dr. Katleya Manlapas, our thoracic anesthesiologist, Dr. Stephanie Balawi, and our thoracic surgeon, Dr. Edmund Paliraman, to the virtual floor.
A pleasant day to everyone. I thank you all for the honor of being part of this panel discussion. The present case highlights a 1-year-old child with Down syndrome with VSD who underwent PA banding early this year. Succeedingly, he underwent PA debanding, VSD patch closure, main pulmonary artery augmentation, and arterioplasty with PFO creation after 6 months. Post-operatively, he was extubated on the 3rd day, for which he did not tolerate, and thereafter, there were multiple repeated attempts on extubation. He was on vent for approximately 2 weeks. During his post-operative course, he was treated with broad-spectrum antibiotics for hospital-acquired pneumonia and was sent home after 24 days, still with coughing episodes and gurgly chest, according to the mom. 4 days after discharge, his cough became more distressing and he has become increasingly fuzzy and irritable with difficulty of breathing. Mom noted noisy breathing and he was readmitted. He was then referred to pulmo service for the evaluation of stridor. Upon referral, the child was noted to be in severe respiratory distress and presented with biphasic stridor. He was also noted to have pectus carinatum and a barrel chest wall configuration with use of accessory muscles. Expectedly, he had poor weight gain because of the increased caloric expenditure owing to the increased work of breathing. Hence, there's a likelihood that this has been going on for several weeks already. Upon referral to our service, he was hooked to a non-invasive positive pressure ventilation with oxygen supplementation and gradually was weaned down to bi-level CPAP with minimal O2 requirements. Pediatric stridor has a variable age of onset, since the extrathoracic large airways are smallest in diameter during inspiration. Stridor is usually inspiratory and becomes biphasic in case of critical narrowing. In pediatrics, congenital stridor oftentimes is not present at birth, but will typically present before the age of 4 months. The most common would be laryngomalacia and other tracheobronchial anomalies. Subglottic cyst or hemangioma or laryngeal papilloma are other less common disease entities. However, a congenital cause is unlikely in our case, as it was never noted during early infancy and preoperatively. But the stridor became apparent after a stormy course, post-operatively, as the cardiologists had difficulty weaning him from the vent. The need for complementary examinations depends upon the history and clinical examination. Hollinger has proposed a stridor history mnemonic to organize history taking and to determine the need for endoscopy in the operating theater. Any positive indicator from this mnemonic presents an indication for airway endoscopy under anesthesia. Her patient's clinical presentation was characterized as severe, and obstruction was progressive over time. And consequently, he had feeding difficulty and failure to thrive. Cyanotic episodes were also apparent, and he even necessitated non-invasive positive pressure ventilation and was oxygen requiring. Signs and symptoms, likewise, were even more pronounced during sleep. Later on, there was also specific abnormality seen on his chest CT. This is just a brief overview of the pathophysiology of the acoustics of Schreider, which may be explained as a result of the Bernoulli's principle. As airflow is forced through a narrow tube, the pressure within the obstruction increases. This creates a vacuum effect distal to the narrowing, and this in turn causes airway walls to collapse and further increase the obstruction, thereby limiting the airflow and causing turbulence and thus producing stridor. It occurs due to the ball valve effect caused by the obstructing lesion. Therefore, the question of what could have caused our patient's noisy breathing was definitely not congenital in nature. It only became apparent after extubation as he underwent multiple repeated intubations. Anyone recently intubated who has shortness of breath should be considered to have tracheal stenosis until proven otherwise. Symptoms may be insidious and not apparent for weeks to months. Prolonged duration of intubation, excessive cuff pressure, excessive motion of the tracheostomy tube or endotracheal tube, having a restless child who was literally fighting the vent, hence with ventilator desynchrony, and thus increasing the risk for barotrauma, were identified as the leading causes of post-intubation tracheal stenosis. So the patient was eventually prepared for bronchoscopy with a double setup tracheostomy procedure. The incidence of upper airway obstruction in children with Down syndrome is noted to be at 14%. Among them, 39.5% suffer from obstructive sleep apnea syndrome, characterized by hypoventilation and nocturnal oxygen desaturation. In the study by Jacobs et al., with 518 patients, among the 71 suffering from upper airway obstruction, 48% had laryngotracheal abnormalities. On the other hand, 86% had pharyngeal abnormalities. Chromosomal anomalies, like trisomy 21, are characteristically associated with a wide range of upper airway anomalies, including tracheal stenosis and congenital heart disease. However, the overall prevalence of severe forms of tracheal stenosis is rare and reported in 1.2% of all congenital heart disease patients. Herein, a rare association of severe tracheal stenosis due to complete tracheal rings in a trisomy 21 patient with congenital heart disease was reported. As mentioned earlier, this case differs from our patient as it is purely congenital in nature. Ours is not a congenital cause. As I end my lecture, I would like to leave some key learning points to be highlighted. In trisomy 21, both airway and cardiac anomalies coexist, and it would be prudent to thoroughly evaluate the airway in those patients with persistent symptoms or in those with congenital heart disease needing interventions. In those undergoing cardiac surgery, it is imperative that an accurate respiratory diagnosis be made if there is persistent symptomatology as it could affect the planning and the risk stratification for surgery. Framing it on the context of our clinical practice, anyone recently intubated or decannulated after tracheostomy and who has shortness of breath should be considered to have tracheal stenosis until proven otherwise. The recommendation is for endoscopic direct visualization as it currently and will always be the gold standard. But as part of the evaluation of cardiac anatomy, it may also be possible to use a three-dimensional turbo field echo MRI or multi-detector CT with 3D airway reconstruction for preoperative airway evaluation. And lastly, just to give a small tribute to this little brave boy with a big heart and a big smile, and to all patients with Down syndrome, regardless of how many chromosomes a person has been given, life is always valuable and worth protecting. Choose to appreciate those who were blessed with more than one chromosome. One extra chromosome just means one more to love.
Maraming puso. Ay, yay. Okay? Maayos yung pakiramdam mo? Kaya mo? Okay, kaya talaga. Hindi ka nahihirapan? Okay, puso kang
It's always nice to collaborate with the anesthesiologists, thoracic surgeons, and ENT towards a common goal, saving our children's lungs and airways. I thank you all for your kind attention.
So I'm Dr. Manlapas, MY, a 1-year-old male who came in with clinical findings of stridor. So the patient had a previous history of cardiothoracic surgery and was prior maintained on intubation. So this is just an overview of the plain CT scan. So this is taken on the long window, denoting the very narrow lumen of the trachea at the level of C71 as compared to the esophagus, where you can also appreciate the orogastric feeding tube inserted. So here are the representative images for cuts. So again, for your reference, so the trachea is the more anterior dark circle that you see, and then your esophagus is the more posterior one, where you can see the feeding tube, here, feeding tube within it. And then again, as we scroll down, there is your trachea and your esophagus. Again, demonstrating the interluminal feeding tube. And some landmarks that we can make use as reference is your sternum, this one. However, there is a significant post-surgical change overlying the sternum or the anterior chest soft tissues. So we can also appreciate bilateral reticular lung densities as well as hazy focal opacity in the left lung, which could be focal pneumonia. As in, this is a coronal overview of the said case. You can see the luminal narrowing. I could start that again. See the luminal narrowing at this area at the level of your clavicle or your C71. So this is the trachea and your esophagus. Again, you can see the feeding tube. So the trachea is more narrow compared to your distended esophagus. And also here on the lateral or your sagittal views, you can see the luminal narrowing from this distended portion of your trachea. And then going towards it, the C71 level, there is a narrowing at this point. So again, a representative overview of the plain CT scan on the soft tissue window. You can just repeat that. So here is your trachea and your esophagus. As it further goes down, you see the luminal narrowing of your trachea here, and this is your distended esophagus. And then as it goes down, there's already distension of the trachea, or no narrowing up to the bifurcation. Just to show you again the 3D reconstruction images of the trachea of the patient, showing you the degree of tracheal stenosis here and also here. So again, that's all for the third case. And again, thank you very much for inviting me for this webinar.
This patient is admitted in another hospital. So the only time that I could do my preoperative evaluation was actually a few minutes prior to the intended procedure. So I have to rely on the medical history and the chest imaging that is being relayed by Dr. Sanchez for me to make my preoperative planning. So based on available data, we have here a 1-year-old baby with Down syndrome, 7.1 kilograms, status post-open heart surgery, with history of prolonged post-operative intubation. Upon review of the chest CT scan, we noted narrowing at the subglottic area. On physical examination, there was audible inspiratory and expiratory stridor with bilateral wheezing on both lung fields. So based on this data, we have this high index of suspicion that this is a case of a central airway obstruction, most probably secondary to a post-intubation tracheal stenosis. So vital in the management of such cases is a multidisciplinary preoperative planning prior to any intervention. So I asked Dr. Sanchez if we could possibly refer this case to our TCVS colleagues, have them review the available chest imaging, and discuss with them possible treatment options and have them on standby during bronchoscopy. So after a multidisciplinary conference, we scheduled this patient for fiber optic bronchoscopy, possible rigid bronchoscopy with dilatation, possible tracheostomy. So bronchoscopy in a child almost always requires general anesthesia, and anticholinergic agent like atropine is usually given at induction. It has the dual benefit of preventing bradycardia that results secondary to instrumentation, and its anti-sialogogue effect improves the efficacy of the topically applied local anesthetic and decreases the amount of suctioning that is required during bronchoscopy. Because the airway is known to be narrowed and we were expecting instrumentation, it may be prudent to give dexamethasone at 6 to 12 milligram per kilo to minimize the incidence of airway edema. So based on the severe narrowing seen on chest CT scan, it is most likely that an endotracheal intubation is not a possible option in securing the airway in this patient. So the only options that I have are the use of a mask or an LMA. Unfortunately, during that time, I also didn't have the LMA size appropriate for his age, so I opted to use the mask instead. So before putting a patient to sleep in this case scenario, it is important to have all the necessary equipments and all the skilled personnel needed to rescue the airway in case of conversion to total airway obstruction. So in this patient, mass inhalation induction was carried out using sevoflurane and oxygen mixture. The hallmark in the management of central airway obstruction is the dictum of don't burn the bridges technique, meaning we should maintain adequate spontaneous respiration until the airway is secured. This approach affords a margin of safety if in case the bronchoscopist is unable to secure the airway rapidly. So before proceeding, I would like to pass the floor to Dr. Sanchez for the bronchoscopy findings.
Direct airway visualization was done using a 2.7 millimeter fiber optic scope. Correlation with the multi-detector CT and 3D airway reconstruction was done prior to bronchoscopy, and it was a double setup procedure. At first, we localized the site of stenosis. The subsequent injury resulted in cicatricial contracture and tracheal stenosis. The definitive management will be thoroughly discussed by our thoracic surgeon.
So once it was established that the trachea is almost 95% stenosed, we proceeded with rigid bronchoscopy with dilatation. So the inhalational agent was shifted to total intravenous anesthesia using ketamine at 2 milligram per kilogram with intermittent boluses of propofol. Ventilation was through a manual low-frequency jet ventilation attached to the ventilating port of the rigid bronchoscope with a driving pressure of 15 psi. Rocuronium at 0.3 milligram per kilogram was given after the airway was secured with the rigid bronchoscope to prevent buckling and possible tracheal injury that could result from airway manipulation. After doing tracheal dilatation, we attempted to insert a size 3 endotracheal tube. However, we still encountered difficulty in passing through that stenotic segment. And at that moment also, we were encountering bradycardia, which we attributed to episodes of desaturation. So we reinserted the rigid bronchoscope and proceeded with doing a tracheostomy to establish a patent airway. So at the completion of the procedure, we reversed the rocuronium using sugammadex at 2 milligram per kilogram. The rest of the intraoperative course were uneventful. The patient was transferred back to the referring institution fully awake with O2 support at 3 liters per minute via tracheostomy mask.
Okay, so this is the rigid bronchoscopy of this patient. After confirming that tracheal stenosis, glottic stenosis on fiber optic bronchoscopy, we did the rigid bronchoscopy here. We're trying to dilate that area of stenosis. This is about 2.5 centimeters below the vocal cords. So it's more or less about 95% obstructed. The length after we have dilated it is more or less about 1.5 centimeters. So this is a complex type of narrowing in that apart from the tracheal stenosis, there was tracheomalacia noted distal to the stenosis. So here we're slowly trying to dilate that narrowed portion, and we have gone through the stenosis. We usually use successively larger rigid bronchoscope sheath for us to dilate this narrowing. So as you go beyond the stenosis, you'd see that there is some form of tracheomalacia distal to that stenosis. So this is that view is the right and the left meets the bronchus. We are slowly retracting the rigid bronchoscope. You could see some area of malasic area of the mid portion of the trachea beyond the tracheal stenosis. That's why in this patient, we opted instead to put in a tracheostomy just below the area of the tracheal or the subglottic stenosis. and bypassed the tracheal stenosis as well as the Malisic segment of the trachea. So the eventual plan for this patient is for this patient to undergo tracheal resection and anastomosis. Thank you for listening.
Thank you, doctors. This case underscored how important team discussion is to promote a better outcome for our patients. In the interest of time, let me introduce the next set of panel discussants. I am pleased to welcome back Dr. Pabalinas for thoracic anesthesia, Dr. Laborte for pulmonary medicine, Dr. Catlea Manlapas for radiologic assessment, and one of Lung Center's graduates from the section of thoracic surgery, Dr. Norman Manlapa.
Our second case is a 68-year-old female who was admitted due to stridor. 10 months ago, she had non-massive hemoptysis, a possible sequelae of a prior PTB. Medical management was done. 5 months ago, a calcified thyroid mass was seen on CT scan. FNAB showed papillary thyroid carcinoma. Surgery was advised, but she was lost to follow-up. In the intervening months, she still had occasional non-massive hemoptysis. Otherwise, she did not have any other symptoms. Until 1 week prior to admission, she was noted to have stridor, which was worsened when supine. A repeat CT scan revealed a thyroid mass with the right lobe extending into the tracheal lumen. She is hypertensive and has good compliance to medications. She completed 6 months of treatment for PTB last 2018. Her baseline vital signs and anthropometrics were as follows. Pertinent findings on airway evaluation were Malampathy class 1 with good mouth opening and neck mobility. A firm mass over the thyroid cartilage measuring 2 by 3 centimeters. No hoarseness, but her stridor was heard best at the sternal notch, which was worst when supine. No other adventitious breath sounds were heard over the lung fields.
So our case is MR, a 68-year-old female who also came in with the chief complaint of hemoptysis. So a plain chest CT scan was initially requested and done. So this is a representative image to show you that this was taken on a scanning protocol plane or level of the mandible. And here you can see another landmark, which is your hyoid bone. And other structures at this level is your piriform recess. And this is taken at the level of your hypopharynx. And again, another representative image showing your thyroid cartilage, which is also one of your landmarks. And then this is an overview starting from the thyroid cartilage, where we see the irregular mass likely arising from the right thyroid lobe, extending intraluminally, causing tracheal luminal narrowing. There's also a calcified nodule seen on the left thyroid lobe. So this is a plain CT scan. And then here is also an overview in your coronal lung window, again showing the thyroid mass, but so with your clavicles as your reference point. So this is your trachea. As we go down, you can see the mass, heterogeneous mass in your right thyroid lobe, at the region of your right thyroid lobe, also exhibiting some calcifications within the lesion. And again, causing intraluminal narrowing of your trachea. So there is no obstruction or narrowing or stenosis at the level of your bifurcation. And these are the plain CT scan representative images, again showing the heterogeneous mass in the right thyroid lobe, exhibiting some calcifications within the lesion. And also here on your coronal lung window, or soft tissue window, you can see the said mass with some calcifications. And again, it has resultant intraluminal narrowing of your trachea. So just to show you, this are our multiplanar views with our CT scan software that can actually pinpoint the said mass in 3 views or dimensions by just a click of a button. So when you click on your actual view decision, these will come up as your reference point. And then the patient also underwent further follow-up with IV contrast. So this image above is your plane, and then on contrast study, the lesion again on your right thyroid lobe has enhanced heterogeneously, and then again it shows the luminal narrowing. So again, a quick overview of the said mass on the follow-up contrast with your mandible as your reference and also your hyoid bone. And then downwards to your thyroid cartilage. And then scrolling down more, you can see the start of the luminal narrowing at that level of your clavicles here. And so that the said mass is there with a heterogeneous enhancement and resultant luminal narrowing. And as you scroll down, there is no more evidence of luminal or narrowing or obstruction up to its bifurcation. So again, the 3 multiplanar views demonstrating the enhancing right lobe thyroid mass here and on your coronal lung window and also on your sagittal view. So the lesion is approximately at the level of your clavicles. Just to show you this 3-dimensional reconstruction images depicting the degree of the luminal narrowing caused by the said mass here and here.
The following were the plans and were also discussed with the patient. Total thyroidectomy with tracheal resection was the proposed surgical procedure. Anesthetic plan was to administer general anesthesia. Airway blocks were explained, as well as a possible front of neck access. Other risks discussed were bleeding and hypoxemia.
Hello, everyone. The patient is then referred for preoperative risk evaluation. And usually, when patients are referred for pulmonary evaluation, usually use the Shapiro's clinical application respiratory care risk assessment. So this is particularly for non-resective thoracic procedures. Now, for this index, we take a look at the spirometry, the cardiovascular, the neurovascular system, the ABGs, and postoperative ambulation. So for this particular patient, if the patient has not undergone spirometry, we evaluated the cardiovascular system, which showed controlled hypertension without any sequelae for more than 2 years. The patient has a normal nervous system and acceptable arterial blood gas. The patient is also expected to have a regular ambulation within 36 hours. Now, if you just use this particular pulmonary risk assessment, you would just come up with a low risk score. But please let us go back to the patient and let's evaluate. We have a 68-year-old female presenting with stridor, hemoptysis, and a tracheal mass. Of course, we know that stridor is a possible emergency condition. The hemoptysis was quickly attributed to the previous treatment of tuberculosis. However, upon assessment of the chest CT scan, there were no particular area in the chest or particular area which showed bronchiectasis, which might be the etiology of or the source of the hemoptysis. And of course, we have the tracheal mass seen in the CT scan. Now, with this kind of patient, with a 68-year-old female presenting with these 3 symptoms, we just have to be careful, more careful actually. The hemoptysis might not be actually be from the bronchiectasis or the previous TB management, but as well, we have to consider that hemoptysis was actually coming from the tracheal mass. So let's focus our attention first to the stridor. Of course, stridor is always a symptom or sign of an underlying disease. An acute onset of stridor always indicates partial obstruction of the airway and a chance of a life-threatening emergency situation should be evaluated. Now, when we look at stridor, usually you look at the grading. Remember, grade 3 to 4, we should might present with severe stridor, which may require immediate hospitalization and emergency management of the airway. So for grades 1, we have exertional stridor. At rest, there are no symptoms, but the stridor appears during exercise or crying. With grade 2, there is stridor at rest. The stridor is present at rest and usually worsen with physical activity or crying. For grades 3, usually the stridor has signs, and it's usually associated with decreased air entry, continuous stridor with suprasternal and supraclavicular retractions. We have a patient who is basically irritable with air hunger. O2 may be normal or may be decreased. We have also a grade 4 presenting with stridor with hypoxia. This would present with minimal air exchange. And in addition to grade 3, patient is now cyanotic and will alter the level of consciousness. So basically, if you have a patient with grade 3 or 4, should be ready to provide support with the airway. So in our patient, particularly, we've seen her as a grade 2 stridor at rest. But nevertheless, the patient might present eventually with problems in the airway. Another issue of the patient is hemoptysis. Of course, if you evaluate hemoptysis, you should be considering not only bronchiectasis, but as well, the source might also be an airway problem. So in the evaluation of hemoptysis, ideally, we should be able to provide or perform fiber optic bronchoscopy. This is not only diagnostic, but therapeutic as well. So we see here the hemoptysis right here. It is an indication as well as a localized possible airway problem. So therapeutic in this particular patient, ideally, it is advised to perform bronchoscopy before any intervention to evaluate if the patient is in fact does bleeding. But this case, I congratulate the attendings for being brave enough to do this, and we truly saved a life. It's very unconventional because, of course, fiber optic bronchoscopy is not available all throughout the Philippines, and it's very expensive. Now, you have performed a service to the patient, so I congratulate you.
Routine fasting and intravenous fluids were started. Other medications given during the pre-operative period were omeprazole, hydrocortisone, tranexamic acid, as well as our antihypertensive medications. At the operating room, standard monitors were attached. Emergency cart contents were checked, and readily prepared emergency airway equipment were also on standby. Atropinization was done. Lidocaine was used for glossopharyngeal and superior laryngeal nerve blocks. Transtracheal block was not attempted to avoid inciting a vigorous cough response. General anesthesia began with pre-oxygenation. Intravenous fentanyl was given, then slow gas induction was started. While gradually increasing sevoflurane concentration, air entry was checked and maintained by a good-fitting mask, as reflected on the reservoir band. Once anesthetic depth was achieved, succinylcholine was given. Videolaryngoscopy and endotracheal intubation was done using a gum elastic bougie as a guide. To further illustrate, there was a marking from the distal tip of the bougie which approximates the distance from the vocal cords to the tumor. Another set of markers on the shaft of the bougie corresponded to the deflection of the cod tip. After passing the vocal cords, the bougie was rotated with the tip directed towards the remaining patent lumen. No tracheal rings were felt. Likewise, no resistance was encountered until it was past the marker for length. Thereafter, the soft tip reinforced tube was advanced smoothly. Placement was confirmed by auscultation and capnography. The cuff was inflated distal to the tumor. Anesthetic depth was maintained with sevoflurane and atracurium. Intraoperative monitoring was relatively uneventful. Moreover, no desaturation occurred. Cross-field ventilation was done with the help of our surgeon. The estimated blood loss was 100 milliliters. Plans for emergence was deep extubation.
We have a 68-year-old female, a diagnosed case of thyroid carcinoma with tracheal invasion. Because of significant airway obstruction, patient needed prompt surgical treatment. On CT scan review, there was no invasion to adjacent structures. Our plan was to resect a short segment of the trachea since only 2 centimeters of the tracheal length was involved. Our goal was complete oncologic resection and to reestablish airway continuity with a tension-free anastomosis. Because of the high degree of tracheal obstruction, we prepared for a possible emergency tracheotomy. The plan was to dissect the area below the tracheal obstruction, then transect the trachea for airway introduction. Our surgical plan was total thyroidectomy, en-bloc tracheal resection with end-to-end anastomosis via cervical approach. Post-op, we maintained the neck on flexion for 1 week. Here is an illustration of tracheal resection. One of the more important steps in tracheal resection, which makes tracheal resection possible, is cross-field ventilation. Let me show some of our intra-op images. We started our exploration with a cervical collar incision with the neck hyperextended. Shown here is an almost complete thyroidectomy with a part of the thyroid fixed on the anterior trachea. Lateral view of the thyroid showing tracheal invasion. The next slide shows the trachea opened distal to the obstruction to start our tracheal dissection. The trachea of the lower border of the tumor has now been divided. In view is the orotracheal tube. To facilitate tracheal resection, the orotracheal tube is withdrawn and the distal trachea is intubated across the operative field. En bloc resection of the thyroid and trachea is now complete. The distal trachea has been intubated, and we can also see here the tip of the orotracheal tube. At this point, we now individually suture the posterior trachea. Once the posterior tracheal anastomosis is completed, the distal airway is removed. The orotracheal tube is advanced and the tracheal anastomosis is completed. And here is a picture of the completed tracheal reconstruction. After surgery, the neck is flexed to release anastomotic tension and guardian sutures are placed. Here is a picture of the resected specimen. The patient was discharged on the 4th post-op day and guardian sutures were removed on follow-up. Patient had no signs and symptoms of airway obstruction.
Thank you very much, doctors, for your valuable insight in the management of mid-tracheal tumors and how to manage with limited resources. But we have to move on to our third case, one that is very difficult to manage. This is a case of a benign tumor in and around distal airway. To discuss this case, may I call on Dr. Stephanie Balawing for thoracic anesthesia, Dr. Laborte for pulmonary medicine, Dr. Catlea Manlapas for radiologic evaluation, and Dr. Villaraman for thoracic surgery.
Major carinal surgeries are inherently complex and require a multidisciplinary approach. Anesthetic challenges includes an abnormal airway, anatomy and physiology, and the need to share that airway with the surgeon while maintaining a good pulmonary function. These cases mandates a meticulous multidisciplinary coordination and close communication among the surgical, anesthesia, and the nursing team all throughout the surgery, especially when the airway is open during carinal resection. It is necessary to have a detailed discussion with the surgeon about the planned surgical steps and the requirements regarding critical portions of the shared airway. So we present our third case, a 38-year-old female with no known comorbidities who came in due to difficulty of breathing associated with orthopnea and stridor. Past medical history revealed a 7-month history of recurrent non-massive hemoptysis.
We have CM, a 38-year-old female who came in with the chief complaint of hemoptysis. So routine or standard protocol is that we do initial chest radiograph, and this image was taken in an anteroposterior view as seen with the scapula slightly inward or slightly in view in the upper chest wall, as well as magnification of the heart and also accentuation of lung markings or vessels. But other than that, this radiograph is essentially unremarkable, so no focal lung opacities were noted. So a chest CT scan was done. So here for your reference is the trachea, which is the dark midline structure pointed by the arrow. And this representative image is taken at the level of your clavicles. So just to show you a quick overview of the study, again, as your trachea, which is your midline dark structure, as your landmark. And as you scroll down, you can see the interluminal mass within the trachea, which exhibits homogeneous enhancement, denoting its vascular characteristic, as well as its resultant luminal narrowing of the trachea. Just to show you again, a coronal view with a tubular dark structure, which is your reference, which is your trachea. And the other structures that you see is your aortic knob, pulmonary trunk, right ventricle, and your descending aorta. Again, to show you the overview in coronal window, where you can see also the mass within the trachea, which is almost at the carinal bifurcation. There. And an overview of the said lesion on sagittal view or window, how closely it is opposing to the esophagus behind it. Just to give you representative cuts or images of the endobronchial mass, an axial view, it is seen at the level of the aortic arc. And on your coronal view, again, it's almost closely abutting your carinal bifurcation. And then on sagittal or lateral view, it is seen closely abutting posteriorly to your esophagus. This was actually signed out officially as a heterogeneously enhancing extraluminal soft tissue structure measuring approximately this dimension at the tracheoesophageal junction. Remember, seen on the sagittal view, it's almost between the trachea and the esophagus. So this was signed out as in the tracheoesophageal junction at the level of your T3, T4. And it indents posteriorly your trachea at this level with minimal narrowing.
So this patient underwent rigid bronchoscopy, coring out of tumor with holmium laser coagulation, stent placement, under total intravenous anesthesia with low frequency jet ventilation.
This 38-year-old female was a stat referral after a pulmonologist did a fiber optic bronchoscopy and noted for a critical obstruction of the distal trachea. So this patient presented with severe dyspnea at rest and orthopnea. And you can see that tumor in the distal end of the trachea. It partially obstructed the right mainstem bronchus, approximately about 70%, and obstructed the left mainstem bronchus, more or less about 90%. So this tracheal tumor is a mixed type of tumor. You can see a component of intrinsic lesion in the center, as well as an extrinsic component, which is actually a submucosal lesion when we review the CT scan. So here, I'm trying to biopsy that intrinsic component, which turned out to be a glomus tumor. And we did also a holmium laser coagulation. This is for the hemostasis. And afterwards, to address that submucosal lesion, that extrinsic component, we placed a self-expanding metal stent, which was a partially covered metal stent to maintain the airway patency. You can see there we've already re-established the airway patency going towards the left mainstem and the right mainstem bronchus.
Patient was discharged improved with definitive plans to do excision of tumor, carinal resection, and reconstruction. However, due to COVID-19 restrictions, the patient was lost to follow-up. On interim, she claimed persistence of cough with difficulty in expectorating phlegm. She eventually came back after 2 months and was readmitted for definitive management. Preoperative workups done showed essentially normal results except for virtual bronchoscopy CT scan, which showed recurrence of the carinal tumor. So patient was scheduled for rigid bronchoscopy, removal of tracheal stent, coring out of the tumor recurrence, video-assisted thoracoscopic surgery, excision of tumor, carinal resection with reconstruction.
So after that, on June 12, 2020, few months after, the patient underwent a virtual bronchoscopy CT scan, as you can see. The findings were there was already a tracheal stent noted at the level of the C6 down to tier T4, and there is a polypoid soft tissue focus measuring 0.8 by 0.9 by 1.8 protruding from the non-dependent anterior aspect of the carina, resulting to a moderate luminal narrowing. So previously it was signed out as a minimal narrowing, but through the visual bronchoscopy, there is already a moderate luminal narrowing of the said mass. So this is at the level of approximately the level of the L4, which is the same level of the distal tracheal stent. So later I will show you how we grade the luminal narrowing. So this was signed out as a polypoid soft tissue focus in the non-dependent or anterior aspect of the carina, resulting to moderate luminal narrowing. There was also a mucosal bulge or soft tissue focus in the posterior aspect of the proximal tracheal stent, causing minimal luminal narrowing or grade 1. Okay, and clinical and histopathologic correlation were recommended.
Hello, everyone. This is a very difficult case, and I would like to congratulate the team, the attendings who actually operated on this patient, and especially the anesthesiologist. When you look at this patient, the usual pulmonary risk assessment or index for non-resective thoracic procedure is not really that applicable. The patient, if evaluated with this tool, would actually present with low to moderate risk only. But if you look at the patient, we have a 38-year-old female presenting with tracheal mass, already presenting with stridor, dyspnea, and orthopnea. Then again, you have to evaluate the clinical grade of the stridor. For this particular patient, we have already a grade 3 of stridor, meaning the patient has decreased air entry, has stridor upon rest, and also already has a air hunger. So immediately you would have to be prepared to do an emergency management of the airway, and be ready anytime, since the patient might deteriorate and proceed with grade 4. So this patient who was planned, assessed to be undergoing carinal resection, involves a lot of planning. First of all, carinal resection is very challenging from the start, from the technical aspects of the procedure itself, from the preoperative preparation, and as well as the post-operative management. Under any circumstances, meticulous attention to details should be observed in restoration of airway continuity. So if this patient was not in an emergency situation, ideally pulmonary function test is required for assessment of the pulmonary reserve and in the aid of decision-making of the medical operability of the patient. Of course, we have to consider some common risk factors such as age, smoking exposure, and of course, the possibility of coronary disease. Now, we have to evaluate the ischemic workup, especially in those patients who will undergo carinal resection. At least usually we have to perform cardiac stress tests. Now, in patients in whom carinal pneumonectomy is contemplated, they should also have undergo VQ scanning to better delineate the predictive post-operative pulmonary function. There should be critical appraisal of this test prior to the resection, especially if the patient is not in an emergency situation. Another modality is SPECT VQ scan, which is a relatively new modality. It allows the precise delineation of the functional lung anatomy, which is very useful in these circumstances. Echocardiography is again very important to evaluate the subgroups of patients with pulmonary hypertension. So usually we have to keep in mind that transthoracic echo tends to overestimate the degree of pulmonary hypertension. And if there is question, we can also we can actually do right heart catheterization if required. For a very cheap test, we can actually do 6-minute walk test, and it provides overall assessment of the patient physiologic status. If available, CPET can be done as well. This is actually to assess the frailty of the patient's preoperative evaluation. So in this particular patient, I congratulate the anesthesiologist and the surgeon. This is a very difficult case. Um, I have just seen just one kind of procedure like this, and we have to stress that there is shared responsibility of the airway between an anesthesiologist and a surgeon, and it requires constant and clear communication of all steps of the procedure. If you look at the case, this case, they communicate very clearly, and especially when to ventilate the patient. They have to pause for some time to ventilate and make sure the oxygenation is stable. Now, again, for this particular patient, if it were referred to me ahead of time, I would have strongly suggested to put the patient in ECMO. But I understand that this time there were restrictions. And of course, their priority at that time was the stability of the oxygenation of the patient. So thank you very much. And I congratulate everyone who was involved in this case.
So anesthesia induction was carried out using midazolam, fentanyl, target-controlled infusion of propofol, and rocuronium. Rigid bronchoscopy was done to remove the stent and to core out the tumor recurrence. Ventilation was carried out using a manual low-frequency jet ventilation system that was attached to the ventilating port of the rigid bronchoscope. So after rigid bronchoscopy, the patient was intubated with a size 7.5 endotracheal tube. The total intravenous anesthesia was shifted to inhalational anesthesia. Easy blocker was inserted to facilitate one-lung ventilation. Proper placement was confirmed using a fiber optic bronchoscope. So bilateral video-assisted thoracoscopic surgery was done to excise the tumor and to do tracheal dissection, infrahilar and pericardial release to facilitate tracheal mobilization in preparation for carinal resection. So to give you an idea on how we manage the cross-table ventilation and an open carina, let me present some schematic diagrams that will be supplemented by a video that will be shown by Dr. Villaroman later. So when the surgeons were ready to open the carina, a separate incision was created at the 5th intercostal space posterior axillary line as an entry point for a sterile endotracheal tube for cross-table ventilation. So upon opening of the carina, the orotracheal tube was withdrawn up to the proximal trachea, while the easy blocker was withdrawn completely. The endotracheal tube at the surgical field was simultaneously advanced by one of the surgeons to intubate the left main bronchus to maintain one-lung ventilation. This endotracheal tube was attached to a sterile circuit that was crossed over to the anesthesia side. At every step of the surgery, I have to be in close coordination and communication with the surgical team, since there were times when they have to withdraw the cross-table tube. So there were moments where I have to tolerate some degree of the saturations due to the apneic ventilation, which were corrected with reinsertion of the endotracheal tube. After some time, however, I was having difficulty correcting those desaturations. So we have to reinsert a second endotracheal tube to intubate the right main bronchus. The proximal end of both endotracheal tube is attached to a Y connector of the double lumen tube and connected to the sterile circuit. So during episodes of desaturation, I have to intermittently interrupt the surgery, intubate the right main bronchus, and convert to two-lung ventilation. Upon recovery, the right endotracheal tube would be withdrawn and the right side of the Y connector clamp. So upon completion of the anastomosis of the posterior wall, both cross-filled tubes were withdrawn and the orotracheal tube was advanced beyond the level of the anastomosis. So upon completion of the surgery, bronchoalveolar lavage was done to clean the peripheral airways. Patient was extubated fully awake with adequate respiratory effort and was transferred to ICU for close monitoring. However, on the second day post-op, patient was reintubated due to post-operative pneumonia. She was eventually extubated on the fourth day and was discharged improved 10 days post-operatively.
So this is a VATS on the right with the patient turned right side up. You can see there the tracheal tumor just above the azygos vein. So we're dissecting along the posterior part of the hilum with the lung retracted anteriorly. So in this part of the video, you could see um, uh, we are transecting the azygos vein so as to better expose the distal trachea as well as the right main stem bronchus. So in this part of the surgery, we're dissecting and trying to separate the esophagus from the distal trachea. So this is the esophagus being encircled, and we placed a Penrose drain to tag it. This is to create a counter traction so we can have a better plane of dissection between the esophagus and the trachea. So you can see there the tracheal tumor. You have there the vagus nerve in between the esophagus and the trachea, which we um, preserved and retracted together with the esophagus. You can see that here in this view, the tracheal tumor, as well as the left main stem bronchus and the right main stem bronchus. So we stapled the Penrose drain for us to have a better traction during our anastomosis. We likewise did infrahilar pericardial release maneuver on both the right and the left. This is to have better length of the trachea when we resect it and anastomose it. So we will have a tension-free anastomosis. So we did that also on the opposite side. In this part of the surgery, we created a port for us to insert that endotracheal tube, which is connected to the cross-table ventilation, so we can better ventilate the left main stem bronchus. So we are now opening the distal part of the trachea, distal to the tracheal tumor. So you can see here, once we have opened up the distal end of the trachea, it's more or less about a centimeter away from the carina. You can see there the bronchial blocker being retracted and inserting that endotracheal tube going towards the right mainstem bronchus so we can ventilate the right side, the right lung while we're doing the procedure. So we're trying to complete the transection of the distal trachea. At times, we would retract the endotracheal tube going towards the left mainstem bronchus so we can complete the transection so we can work. After doing the transection, we would reinsert it. So intermittently, we would ventilate this patient. So after completely transecting the distal end of the trachea, then we reinsert the endotracheal tube going towards the left mainstem bronchus. So in this part, we're trying to dissect the proximal end of our proximal or the mid part of the trachea, which is proximal to the tracheal tumor. So we're completing the posterior membranous part of the transection along the proximal end of the tracheal tumor. This both sides of the resection were sent to frozen section for to check for the margins of resection. We noted at times our saturation would go down and the ventilation towards the left wasn't enough, so we created another port and inserted an endotracheal tube going towards the right mainstem bronchus to ventilate the right side of the lung. And this really helped ventilate the patient. So we would intermittently stop to ventilate the patient, then resume our surgery while the ventilation is discontinued, then we would reinsert it. So that's the reason it took some time before we actually completed the transection and anastomosis of the distal trachea, because we have to intermittently ventilate, then retract the endotracheal tubes, and then do our anastomosis. So here we are trying to complete the anastomosis along the anterior side of the tracheal anastomosis. We have already retracted that cross-table ventilation through the endotracheal tube, and the endotracheal tube that was placed proximally was then reinserted going towards the lung. Here we're applying now a synthetic glue to reinforce the anastomosis. A month after this patient came back because of a narrowing of the left mainstem bronchus anastomosis, so we had to do a rigid bronchoscopy and dilate that narrowing. Eventually, that narrowing was only a minimal web-like structure that we were able to dilate, and this did not recur since.
Congratulations for successfully managing this case, doctors. This case is clearly an example of what good multidisciplinary teamwork and communication can do. The floor is now open for questions for the members of our panel. And that sums it up for our panel discussion. We thank everyone for joining us today, and I hope we all learned something new in the management of central airway obstruction. If there's one thing that we can take away from this panel of experts, it is that good and effective team communication and collaboration does wonders in the treatment of our patients. Not one team member is expendable. In behalf of Astaphil, this is Team Ila Ramos, and thank you for your participation. I wish you all a Merry Christmas and a better year ahead.